네, 시작하겠습니다. 외국인 펠로우 선생님들 계셔서 영어로 진행하도록 하겠습니다. Good morning. We're about to start the electrocardiogram conference today. My name is Tae-in Kim, and I'm a first-year fellow of general cardiology. This is the electrocardiogram we are about to discuss today.
Designated is the first reader of the ECG. That is your right, present right.
Dr. Seong Jung.
Thank you, Dr. Kim. And I can see irregular R rate, and maybe the heart rate would be about 100 to 150, and also I can see the regular P wave. I think is continuing from start to the end, and looks like the AV conduction is forever, and I guess this is atrial flutter, and when we think about the P wave axis, I think is maybe neutral or slightly positive in lead 1, and I guess it's positive for 2-3 AVF. So I think the P wave is coming from the central and top of the heart, and so that's my conclusion. The atrial flutter with variable AV conduction, and the P wave would be came from the center and top of the heart.
Thank you for your comment. Would you like to make any other comments, Dr.
Josiah.
Josiah?
No additional finding. Dr. Pagumadulam.
Water wave in negative in lead 1 and positive in V1 and inferior leads, and AV variable AV conduction V21 and G2 AV conduction. Water with variable AV conduction.
So is this typical atrial flutter? No, atypical or organized atrial fibrillation? How do you differentiate it? So when you see the ECG of atrial tachycardia flutter, not only P wave, but also you need to carefully observe the QRS. There is a 3 root beat, 2, 2, 2, 2, 1, and 4. I don't know, there is another 4. So is there some regularity? Some areas are regular, right? But like a cardiac ballet. But there it is broken here, and the 4 beats, 4 consecutive beats. But the QRS morphology is same, right? So what does it mean? Dr. Carroll? for Dr. Lee? The characteristics of atrial fibrillation ECG is irregular QRS, right? But is this regularly irregular or irregularly irregular? Regular irregular, but there's some breakup of regularity in this area, later part of the rhythm stream. So I guess it is the atypical atrial flutter or atrial tachycardia, but sometimes the atrial rhythm is disorganized transiently, or the tachycardia circuit, reentrant circuit changing from time to time. Oh, Dr. Huang is here. Good evening, Dr. Huang.
Good afternoon, sir. How are you?
Very good. Welcome back.
You can hear me?
Yes, clear.
Okay.
Please teach us.
So what is the probability of, let's say this is atrial flutter versus atrial tachycardia, which is definition is not really clear sometimes, but it's based on the rate. This would favor for atrial flutter or atrial tachycardia. Let's talk about only rate alone. What is the type 2 or type 1 atrial flutter rate usually we consider? Do we know?
To whom are you asking?
Oh, my fellows, anyone. This open conference.
Dr. Huang. Dr. Huang too. Dr. Huang is one asking you. Is asking you.
Usually 300 beats per minute.
Okay. So what's the rate of this tachycardia?
What's 300?
Yeah.
About 300. Oh, a little bit slower, perhaps.
Yes.
All right. So this is where we get a lot of unclear definition about the atrial flutter. If this atrial flutter is an atypical atrial flutter, right?
Yeah.
Because your F wave, flutter wave axis is not usual. Second thing that you pointed out, Dr. Park, very important. What is the probability of atrial flutter O versus atrial tachycardia can develop Wenckebach behavior? Which one is more common in your experience? I'm asking.
Flutter.
Flutter? Not atrial tachycardia?
Atrial tachycardia, usually the P wave rate is slower and mostly one-to-one conduction. I mean the ectopic atrial tachycardia
Yes.
with the mechanism of triggered activity or automaticity.
Uh-huh.
Most of atrial flutter is reentrant mechanism, and
Right.
flutter rate is quite faster, so that's why we see the grouping QRS morphology.
Yeah, if I may ask you, do you just mention mechanism of automaticity or focal localized micro-reentrant tachycardia going to the AV node Wenckebach cycle versus reentrant atrial tachycardia or atrial flutter, which is a similar mechanism, which one is more likely to AV node Wenckebach, you think?
It depends on atrial rate.
Well, you gave us already 300 beats per minute. You already told me that. So what type of tachycardia can do this fast? You first discussed and, fellow discussed, and he told us that this is not the right atrial tachycardia. At least that's what I understood. Am I correct? Is that what you meant? Right? It is not a right atrial tachycardia, lopsided tachycardia.
Yes, sir.
Yeah, because AVL is a negative. You see that most negative P wave is an AVL. What did that tell you? Is it coming to the left to the right, right?
Yes.
And then B1 is positive, so it's a posterior to the anterior, and then superior to the inferior. What structure might have over there? I'm just giving you anatomic description here now. So tachycardia, they originate from posterior, left side, superior to the inferior axis. Which one that tended to have this type of behavior? Most common type is what? Somewhere in the pulmonary vein area, especially left side one.
Yes,
That would be the potential first prime candidate.
right.
Cannot be anterior tachycardia because the V1 is positive, right? So only few tachycardia can do this. Now, if you have let's say, patient undergone pulmonary vein isolation, let's assume, they are incomplete. Now pulmonary vein fires, even though PV inside the reentry, but the exit site is very narrow, behaving like a single source of tachycardia for the rest of the atrium. Then you would have what we call pseudo automatic tachycardia, actually mechanism reentry inside the PV. But because you create a conduction block to the atrium, so they coming out of a single narrow channel where they can fire this fast. Now those type of tachycardia can exhibit AV node Wenckebach. This is AV node Wenckebach. That's what you see. So we call double block Wenckebach because the AV node conduction is there, baseline block, and then further down you have to have a Wenckebach behavior. So that's what Dr. Bach described the cardiac ballet. Okay. So Dr. Bach said that it is more common in the re-enter mechanism rather than automaticity, typically, but exception is PV tachycardia. Okay.
What about the ligament Marshall tachycardia?
Okay.
Ligament
Ligament Marshall tachycardia is
tachycardia first time in the world.
understood. Ligament Marshall tachycardia is somewhat, unclear to me at this point because if you look at the V1, V2 transition of P wave, can you see that? P wave transit too early, V1, V2. Ligament Marshall tachycardia is originating from the more inferior posterolateral wall. So V2 still, I should see some positivity much more than this. And second thing is that against the ligament Marshall is that because the ligament Marshall activate posterior through the coronary sinus musculature, you should see more negative biphasic lead 2 and 3. We have a positive P wave. So I would do not bet ligament Marshall origin tachycardia here. I think more sort of a PV or left lateral ridge area, re-enter mechanism tachycardia. That would be the first bet I have. Second would be obviously macro re-enter tachycardia around the, could have a mitral valve isthmus flutter. All those can possible, but then mitral valve isthmus does not give it too much V1 positive. They tended to be biphasic.
So you meant the ECG characteristics of ligament Marshall tachycardia is biphasic P wave and lead 2 and 3. Am I right?
Yes, correct.
Okay. Thank you.
And transition is usually V3, V4. Okay, P wave. So what happened with the patient? How do you manage this patient now?
So the patient had a variety of cardiac history. She was a
Okay.
76-year-old female. And this time she came with a shortness of breath starting about 3 months when climbing stairs, but she did not have symptoms when walking on flat ground. So previously, she first came to our hospital with symptomatic paroxysmal atrial fibrillation in 2019. And she had an RFCA for AFib. And later, the next day, she presented with tachybrady syndrome. So she had the DDDR pacemaker implantation. Later in 2024, November, she experienced similar symptoms of shortness of breath when walking. So she had a second RFCA for the lateral anterior wall mitral annulus with IART. And then this year, this was the third RFCA with LA roof-dependent IART. And for her medical treatment, she had apixaban 5 milligrams twice a day, dronedarone 400 milligrams twice a day, and carbidopa, furosemide, and atorvastatin. And then after RFCA, we had a dose reduction due to her hypertension, low blood pressure, and dronedarone was discontinued.
Okay. So this is a tachycardia that exhibit from the roof posterior to the anterior, activating tachycardia.
Yes, that's
Am I right?
Yes, that's right.
Do you have
Okay.
some
Yes.
mapping result?
This was the mapping from the third
Yeah.
study.
Could you
That
explain?
makes sense.
So the for the first 1 to 5th ablation, it was at the anterior wall. And then the 6th to 20th ablation, it was on the roof line here. And then a flutter was terminated.
Mhm.
Yes. So
Is this just the sinus map or tachycardia map?
this,
I'm sorry, this is ECG sequence. I forgot it.
Well, this tachycardia looks like a map. Sinus would not look like this.
this is I believe is a tachycardia map.
Yeah, it is. Okay. So basically, they left a gap in the roof. Therefore, they have a basically coming from posterior to the anterior activation wavefront. Okay.
The
So
seismic
EKG can tell us a lot of things about the patient's history as well, but then obviously a little bit of clinical experience also helps to understand the EKG a little bit better. But the important is that when you see such a distinctive P wave morphology or flutter wave morphology or atrial tachycardia morphology, whatever it might be, you really try to make a sense looking at the vectors and then activation sequence so forth. You will try to learn more. I think differential diagnosis we made probably reasonably good, and I think your guessing where it might be was very good. Now you notice that the one thing that I want to just point out here for the teaching standpoint, I know it's an ECG conference. Look at the way where they ablated the very first time in the anterior wall. Where this thing is. It is just between the LSPB and the appendage base junction. Is that where they ablated? That looks like to me that way, right? That's appendage. And then the blue is up in the left superior vein. So that junction point between two. So it's upper ridge junction between the appendage and the LSPB. I'm just wondering, what was the mechanism there? Was a micro reentry there? They did not create a linear block. They just looks like the focal ablation. That would be curious. Maybe worth to take a look at it.
But
And
that's
then
procedure.
I hope they remap this area again. I hope they did. Could it be a same tachycardia deeper negative? You could raise a question about that, but I don't know.
Dr. Lee attended the procedure of this case.
Based on activation map, there's it shows the reentry based on that point. So
Okay.
ablation was started in that point.
So which one is for you? Which area did Dr. ablate first? Appendage base or roof line?
Appendage.
Appendage base first. But the tachycardia sustained.
Yeah, sustained and review the activation map, and it decides to ablate the roof line.
Okay.
Is this map was done with the Octaray or something? What do they use?
Yes, he used Octaray for the mapping.
Octaray. Okay, that makes sense now. All right. We'll discuss at some point about this high density mapping, catheter selections, all those issues. So hopefully we can get to that some point this year or next year with the Korean junior rhythm. So I think that's important to understand why the map is look different. Okay, great.
So Dr. Wang, I have a question for you.
Yes,
So
sir.
in patient with significant structural heart disease or post PB isolation status, so
Yes.
do you think the ECG P wave we can localize the location of tachycardia based on the ECG P wave? Because the Kessler and Karman reported the ECG oriented the tachycardia localization long time ago, but it is the structurally normal heart or the
Yes.
de novo ablation cases, right?
Yes. Because of your substrate structural abnormality, not just by underlying disease, but also ablation we created, we're going to have some conduction block delay. So if you go back, take a look at your 12 ECG, I just want to point out something for you. Look at that ECG, clinical tachycardia. If you look at the carefully lead 3, there's an initial component of negative. You see that? Even though
Oh,
almost
yeah,
like a biphasic, right?
yes.
What that mean? There's a significant intra-atrial conduction delay going on. The source of tachycardia versus actually local EGM vector. So this patient had a significant intra-atrial conduction delay. However, interpretation of P wave should be whatever is the dominant largest component, which is a positive. That's why I did not want to bother discuss with you because I don't want to confuse my fellows. So if you look at such a notched P wave, you have to assume this patient have a significant intra-atrial conduction, or maybe interatrial conduction even, delay. Therefore, your interpretation should be very cautious. However, this is favor for what? Re-entry mechanism, okay? Because there's a lot of scar itself. That's what they mean. Now, there's another point important here is that if you look at the lead 2, is isoelectric, that first component. Can you see it? It's flat, right? That itself also tell you coming from roof to the bottom, because the lead 2 is almost 60-degree angle. Your left atrium is almost tilted up, therefore has to be isoelectric. So it is a tachycardia circuit that circling isoelectrically to the lead 2. That's what they mean. I think so. There's a few things that you're pointing out. Your question is a very important one, but then you need to understand. So you need to look at the AVL, initial vector is positive, then become negative, reverse of lead 3. Do you see it? Initial small R wave, sort of R wave have a P, then S wave become deeper. So this patient vector, you can calculate that. It's definitely not a classical PB tachycardia. But beyond that, I don't know whether you can make any more sense out of it. Make sense?
Yes, makes sense. The most
Great.
of post-ablation atrial tachycardia experienced a multi-loop reentry, not the
Right.
single loop reentry. So
Right.
I had a similar experience. The earliest activation site was based on appendage, but after ablating that area, it changed to the loop-dependent atrial tachycardia. Because I guess it is my speculation that if the tachycardia circuit involves the Bachmann's bundle and the septopulmonary bundle going to the appendage and both roof to posterior. So if blocked one area, the other circuit, the circuit changed, the main circuit changed to the roof dependent tachycardia. So because it is the ECG conference.
Right.
Stop.
You will see much more pronounced this type of fragmented P wave in post-MACE patients. Okay, so when you read the post-MACE patient tachycardia, you really want to compare with the sinus rhythm P wave, make sure that which one is conduction delay, which one is not. That would be helpful for you to interpret the tachycardia. Okay.
Okay. Other slide.
Because you did not show us a native P wave, it shows a paced ECG. That's why I did not want to comment it. You see, your EKG post-ablation is sinus rhythm. Is not a sinus rhythm, atrially paced rhythm, right?
Yes,
So you can
This
tell
one-
which of the P wave looks like. Oh, that's a sinus. Okay.
this was the last EKG taken.
Yeah,
after-
intermittent paced. Yeah. Okay. So P waves are quite reduced. Okay. All right.
Yes, sir.
Okay, thank you.
Thank you.